Hello, my name is Manj Gohel. I'm a vascular surgeon in Cambridge University Hospitals, but also a member of the Charing Cross Venous Executive Board.
Hi, my name's Daniel Carradice. I'm an academic vascular surgeon in the Hull York Medical School.
I'm Alun Davies. I'm the Professor of Vascular Surgery at Imperial College London, and I work at Charing Cross Hospital and St Mary's Hospital London.
So three of us are meeting here today and we're going to talk about leg ulcers, a very topical area. And I'm just going to start by asking your perspectives on what's the scope of the problem of venous leg ulceration.
The scope of the leg ulcer problem could actually be regarded as a case of national emergency, because there are at least 2% of the population will at some point have ulceration in the leg. If you look at those people over the age of 65, this goes up to 4%. We know that on many figures and data that there is evidence that we spend 2% of our NHS budget on looking after patients who have leg ulceration. This is seen on a global aspect, that if you look at the American healthcare budget, they spend a similarly 2 to 3% on the management of healthcare for patients who have leg ulceration. This is often done in wound centres, which is not something that we have in the UK. In the UK, we would very much rely on primary care, where there is either a general practitioner or a nurse who is responsible for looking after the patient and then making a decision as to whether they will refer that patient on to secondary care.
So, I mean, some astounding figures there about the extent of the problem. I mean, Dan, any perspectives on the patient's sort of perspective?
Yeah, I think venous disease in general is often badged as a cosmetic problem primarily, and I think it's really important that we recognise the amount of impact that this has on quality of life, and certainly there's good evidence from quality of life studies that this has a profound effect across all domains of quality of life, but it's particularly linked with physical disability, and certainly is seen as equivocal as a group of patients who have end-stage COPD. The pain associated with these ulcers has been judged as being equivalent to patients with unstable angina. So I think that gives some real sense of the importance of this disease. But it also has this additional element that people are trapped in their home and becoming socially isolated, waiting for regular dressings. And this is perpetuated by a belief that this is a chronic disease that requires long-term management in the community.
So what's really interesting is the quality of life impact on the patient, but also on the relatives and the people around the patient, and some really startling work that's been done in that area. So, I mean, there's been a lot of research in the area, and one of the key trials that we were all involved with was the Everett trial, and I think we've really been able to move the needle on this. So, Alan, can you just summarise for us the main findings from the Everett trial?
The Everett trial was very much designed to, in a way, look at the situation with respect to where we should go with respect to offering endovenous intervention early for patients with leg ulceration. They'd previously, about 15 years ago, there'd been a trial conducted from Cheltenham, which is called the ESCAR trial, that had shown very clearly that there was a benefit in reducing leg ulcer recurrence by using simple surgery, and that was a landmark trial that has been quoted all over the world. The Everett trial was very much set up to look and see if these new modalities of either endovenous ablation with laser, radiofrequency, glue, foam or mocha would actually help with respect to leg ulcer healing, and as to whether that treatment pathway, if people were seen early, was going to be cost effective. So there were two groups in the Everett trial. There were those that were called the early group, which were seen and then had their treatment conducted within 2 weeks, and they were then subsequently followed up, as opposed to the deferred group, who were offered endovenous treatment once either their leg ulcer had healed or at 6 months if the leg ulcer had not healed. The basic findings of this trial were that if you were to have early intervention, this meant that your leg ulcer was much more likely to heal, and over the first year you were much less likely to have a leg ulcer present. The strategy of offering early intervention was undoubtedly cost effective, looking at what we look at in the UK, the NICE guidance and a willingness to pay a threshold of £20,000 per ISA. So overall, the Everett trial was very positive. It was published in the New England Journal of Medicine, and we have undoubtedly heard that many of the guidelines around the world will be rewritten, taking this on board, because it is really the first trial to provide level 1 evidence of the benefit of early intervention on healing.
So it's worth highlighting. I mean, the healing rates in the Everett trial were astounding. They were, even in the group with compression alone, 75% healed at 24 weeks. I mean, the highest healing rates in any randomised trial. So it really shone a light on how good the results can be with good care. But I mean, one of the issues has been implementation, and we all know about enormous variation. And Dan, you've done some really important work looking at variation in provision of venous treatments. I mean, can you tell us a bit more about that?
Yeah, so what we've seen is that overall, looking at all disease associated with venous reflux, about 90% of people are never offered the treatment which NICE recommends. And we looked at policy nationally in this area and found that, or across England, should I say, and we found that the commissioning groups had quite a wide variety of policies with different measures put in place to limit access to treatment. And overall, only about a third of CCGs in England were offering the NICE recognised treatment pathway. But that's just part of the picture. I think we also need to look at issues with referral, and when we focus purely on the venous leg ulcer group, over 2/3 of these patients never receive vascular assessment. So that's a real barrier that we need to consider how to overcome.
Yeah, so as much as we all like to blame the commissioners and the payers for everything, it's such a complex problem, isn't it? Because patients don't refer don't seek help. Primary care referrers don't refer accordingly, so it's a very complex problem. So how do we start to break down those barriers to implementation?
Well, I think the key things are education, and the key thing is that there are a lot of people who need educating. Firstly, the patients themselves need education because sometimes people are ashamed that they've got a leg ulcer. They've known a family relative who's had one, who's lived with it for years. So I think the key thing is that we need to get the information out to patients that there are suitable treatments and that they interact with either the nurses or the doctors that they're seeing to say, well, actually, I do need to be referred on. We also need to get the message out to the other medical practitioners, such as the GPs and the nurses in practice, that there are actually treatments that are available that will actually not only get the leg ulcer to heal, but improve the quality of life of these patients, and importantly, reduce the workload of the district nurses in the community who are having to regularly bandage these patients, can be often up to 2 or 3 times a week, even though there are some bandage techniques that will last up for a week.
And what do we say to the payers and the politicians who say we simply can't afford these treatments, Dan? I mean, how do we address that argument and that perception?
I think we've got clear evidence now that this is not only a cost-effective treatment, but this is actually cost-saving. So by not engaging with improving care in this area, I think it's clear that we're actually wasting money. This is one of those rare golden opportunities in healthcare where you can not just improve quality, but you can actually save money at the same time. And we need to grasp that opportunity with both hands.
So I'm sitting here with a copy of the All-Party Parliamentary Group report on leg ulceration, and this was an important political initiative to try and raise the profile. Dan and Alun, I mean, tell me your thoughts on what the impact of engaging politicians can be, do you think, in trying to improve care?
I think it's one of the key features because we treat people within a nationalised health service, and politicians are the people who need to influence how the money is spent within the health service. Leg ulcers for many years have been regarded as a Cinderella part of the disease process, just bandage the patients out and they then go away. But we've now shown that there are good treatments there, and I think by actually getting politicians on board will actually help us to be able to influence people to actually be offered the appropriate treatments. And I think the other key issue is that we actually, as specialists, be we looking after these patients, need to be championing the cause of patients with leg ulceration so that we, in secondary care, make sure that there are the facilities for these people to be treated in an appropriate manner and within an appropriate time interval.
Yeah.
I agree. I think we're very keen to point out how neglected patient groups are, particularly within vascular disease and more so within the venous community. But we need to be clear that we're doing everything that we can to ensure that the correct information and knowledge about the experience of these patients and the quality of treatments and the outcomes that we can create will have, and we need to promote that not just to politicians but also to the media, which is often centred on other more high-profile disease.
So the other comment to make is that multidisciplinary working is so important in this area, and there's some really important work done by Una Adderley and the National Wound Care Strategy Group in all working together and pushing the same direction to make a move. I'm just going to, sort of the last moment or two, try and globalise this. I mean, it's obviously an enormous problem around the world. How relevant do you think the challenges we have in the UK with implementation, how relevant are they to North America, Europe, Asia?
My understanding, talking to colleagues and taking part in sort of tripartite discussions, is that they are confronted with exactly the same issues, because, for example, if we were taking the example in the United States, they have wound clinics where people go to and get recurrent bandaging, but at least 70 to 80% of these patients who are in a wound care clinic do not get a proper vascular assessment in an appropriate time and an appropriate intervention. And you may say that that is related to the way in which the system is funded. But I think the point that, as Dan Carradice pointed out, that actually by early intervention and appropriate treatment, we are actually saving, whoever the payor is in the long term, we're actually saving the money. So in a way, it is a slightly no-brainer, and the same things apply in Europe and in Asia, where patients get leg ulceration, that the sooner they can be seen by a specialist. And if you want to look at it in a slightly more long term, if you could actually get the majority of patients referred early for intervention, we may, and it's maybe a pipe dream, actually get rid of chronic leg ulcers that sometimes only present at 1 year or 2 years to secondary care. And I think we really have quite a way to go, but I think we've got all the building blocks and evidence to actually make a significant impact on the quality of life of patients in the whole of the world.
Yep. Dan, any final comments?
I think when we consider the global view, we often neglect the lower income countries, and actually the infrastructure that's required to perform high quality community based compression treatments is very difficult and expensive to put in place. And you're looking here at a one-shot treatment which has a very high efficacy in healing. So it has to have even greater benefit in those kind of environments.
Yeah. So that's great. Thank you very much to both of you. I think we're in an exciting time where we've got the building blocks and the foundations to really improve patient care, and let's hope the next few years brings that. Thank you very much.
Thank you.
Thank you.